attention, and I hope that I don't speak too long and bore you where you then have to fall asleep. Anyway, thank you. So if you want to leave, you got to leave now, because Joanna told me that when I start, they're going to lock the door, so you can't get out. Tell them.
I didn't say that. Don't pull that to me, okay?
Okay, now, here's a case that I did like last year. And like anything else, it's a growth process, it's an evolution, and you're continually striving to try to get better, all the time. And to create the perfect imperfection is almost impossible. But now, when I do immediate implant placement, I didn't show you doing a connective tissue graft at the same time I do the immediate placement. And now I do connective tissue grafts with immediate placement to allow a bulking up of the tissue, and the end result is far better. So this particular case here was not an immediate placement, but because of the tissue, we elected to do a connective tissue graft in conjunction with the placement. Here's my surgical guide to control my axis. Again, the principle of maintaining your space. So there's my surgical guide. I know where my CEJ is exiting out, and I'm going to go down in each direction and place my implants. There's my implants that are in. Using the CT guide, someone said, well, sometimes you can't use the guide 100%. Sometimes you have to take the guide out and maybe complete the osteotomy without the guide in. So here is the implants that are in. These are Blue Sky internal hex implants, and they are, the line is my CEJ, and these are the space, the distance apical to the CEJ in order to create my emergence profile. Now, here is a case where I wanted to try to bring the tissue down a little bit, so you can see in here we did a CT graft, and all you do is go and take the connective tissue. You set it on the inside. You can see there's a gut suture. Just kind of tack it to the inside of the flap before you replace the flap. So there are my two implants in place. I made screw retained temporaries. This is the screw. This is the temporary here, and here's my custom abutment, opaqued, so I could use Emax crowns. This shows the nice tissue development, and look how nice this is here. That's because of the CT graft, by bulking out the tissue. So I used the provisional, screw retained provisional to develop the tissue, but I couldn't even develop that tissue to that extent had I not done the CT graft in conjunction with the placement of the implant. So here are the final crowns. And even though we still maintain a pretty good level of soft tissue development in there, but I wouldn't have been able to do that unless I did the CT graft in conjunction with that. So here's an immediate case, and I did a CT graft in conjunction with this. Now, what we're going to do is we're going to extract the tooth. We'll take a micro elevator, and take the micro elevator and take it and push it up underneath there to create like a little pouch after we get the tooth extracted. And then we're going to take and place some grafting material in there. And then we're also going to do a CT graft in conjunction, because if you look close at this, you'll see how this has a nice tissue contour. But when you take that tooth out, everything is going to extract, is going to shrink in. So with the flapless approach, you always make sure you get the implant to the lingual. I graft the defect, and actually the trend now is to graft the outside labial even more so than the inside of the socket. So here's my implant in place, my healing abutment. You can see how this is all puffed out, and there's my suture for my CT graft that I placed in there. And you can get the CT here. I just went back into the retromolar pad area and made an incision, took a fillet of the connective tissue, and then used that. So then, in order to not have any pressure on that, put in an Essex retainer. So this shows how much this was built out. And the concept now is to build it out more and it'll shrink down. This just happens to be that Cybron implant that has the same octa connection, but it's a bone level implant. So this is the way it looks in 12 weeks. There's the implant with the healing abutment out. Take an implant level impression. Make my custom abutment. Now this is a Strawman. I don't think Blue Sky has these. A Strawman peak temporary abutment to make my provisional with. And you can see here, you don't have a tissue fill. There's my temporary. So I had an implant level impression. I took my temporary off. I put my temporary on this model and then injected this polyvinyl siloxane around that to capture that replica of the subgingival contour and space. There's the custom abutment that's it. And here's the final restoration. Here's the final restoration. You see the nice tissue and you can see the papilla. As opposed to when I showed you on my temporary, the space. And there's the papilla. There's minimal, if no shrinkage at all. A nice emergence profile. And that's her smile. So we started here. Temporary, the papilla's not there. Here's the final, it's there. So with immediate placement, now I always use a CT graft in conjunction with the placement, and we augment the bone, especially on the labial, to develop the tissue. So here would be another example. This was a cuspid. It's going to be an immediate extraction and immediate placement. The line gives you the reference of where the adjacent CEJs are. Here is the distance of, this is the tooth itself, and I'm going to end up with my implant platform about here, and then I'm also going to do a CT graft in conjunction with the placement of the implant. So this is a week later. Here's my CT graft that's doing a little bit of fluffing, and the sutures are still in position. That's from a occlusal view of it. There's the Essex retainer that's in place. Now here's the final, the temporary healing. Here's the line for the reference point, and then my platform is up here. And this is still the contour of the gingiva that was there that has not shrunk. So that's healing abutment in place. And in conjunction with the CT graft, you maintain a nice aesthetic contour there. Here's a provisional in place. And then what happened was this tooth became a problem before I had completed this one. So this is my provisional. This implant is in, the provisional is on, and the implant had already integrated. And I was just developing my tissue. I wasn't planning on doing this, but then this tooth became a problem. So we ended up going back in and extracting that tooth. I'll show you as we go along. But you can see how you can predictably maintain that level of that tissue. So I had this provisional on this temporary peak healing abutment. I came over here, I extracted that bicuspid, and she didn't want to wear an appliance because she had worn that Essex. She was tired of it. She was in a provision. She goes, oh, no, I got to wear something removable again. I don't want to do that. So I put in an immediate implant. I put in a temporary abutment into that, and I just splinted those two together because there's no concern for movement because it's already split into an integrated implant. So I made this screw retained, and I just tacked the two together. And then this is like a week later when the removal of the teacher. So this is implant is in, temporary already integrated, and there's my immediate placement there. So this is healing up. So then we make our custom abutments in this case. There are my two implants in place, and those are my final crowns. And you can see that the height here is very similar to when we started. But in that particular case, I did a CT graft here, but here I didn't do a CT graft. I mean, I could have, but I just didn't do it because it's not in that aesthetic zone. Here's another situation where it's an immediate placement. This was all part of a bridge. She's probably in her late 60s. This tooth has to come out. I sectioned it. This was all connected. We took and sectioned this here. We extracted the tooth. Now, you can say, if you extract the tooth, you can see how much recession we had there. So we extracted the tooth, we placed the implant, and did a CT graft all at the same time. So now this is 3 years down the road. You can see where we started here. You can see here's the CEJ of this pawning. This is not going anywhere. This is stable. This is a pawning. You can see the distance here. And you can see how much added tissue we gain by doing the CT and also preserving the tissue. And this is 3 years post-operatively. So I think it's really, really good with in the aesthetic zone to use CT grafts in conjunction, especially in immediate situations. So again, this is that process again of using the depth gauge and placement of the implant. You do it at those with a flapless approach, and you're not releasing any flap at all. And then also in her particular case, we made an immediate provisional. We went back into the posterior area and took the CT graft there. So this is this day one of the surgery with placement of the or extraction of the tooth, the placement of the implant, making of the provisional, as well as doing the CT graft. This is at 2 weeks. There's a solid abutment. And there's our final restoration. So, here is another situation where all these 4 teeth are going to come out, and we're going to do immediate extraction and immediate placement, followed with an implant in this area, an implant in this area, and then 2 ponics. So, there are my teeth, and you can do this a couple different ways. If you wish, you can take this one more tooth and come up, or you can make your incision here. So that's when we laid the flap to see exactly what was there. So if you were making a determination, it'd probably be a lot better to place an implant here than to place one there. So we place one implant here and one implant out. After we evaluate the bony profile at that time. So here's the extraction of the teeth. And there was a couple little perfs and holes there, but that still didn't prevent me from going in, placing the implants, grafting it. So there are my 2 implants, which are 4.1 diameter bone level implants. And in this particular instance, I elected to, because of the amount of periodontal disease that was there in the recession, we extracted it, we laid that flap up, released the flap, and then we advanced the flap slightly to get primary closure. Then we put in an Essex retainer. So we wore the Essex retainer, then we went back, we uncovered the implant and put these larger healing diameter. So when we exposed these, we took the cover screws and put these tissue formers in. After wearing the tissue formers, you can see how that created that nice soft tissue profile. One thing is, if it is more difficult with these narrower diameter implants, if you leave this out, leave the room for too long, you come back, it collapses in, you can't find the implant. That tissue collapses, so when you're going back and forth, you have to work rather fast. So This is a one of those peak healing abutments, a different kind, but it's the same concept. So there are my healing abutments. I'm at my temporary post, and then we made a acrylic temporary and started the development of the tissue. Here are my custom abutments, and this is going to be a cement retained bridge. Kind of went back over on this side over here and developed a little bit of an ovoid ponic to try to create a little bit of appearance of a pillar there. It really doesn't matter because it's smile line, he's not going to see it. Here are my abutments, and here's what the final bridge work. So by going in and making that ovoid ponic, at least you create the illusion of a little bit of a pillar there. And that's the final result. Here's another one of those cases where we have gone in and we did post. This is basically a full mouth, almost full mouth maxillary set of implants. We did the posterior first. I like, if all possible, to keep a cuspid if I can. A cuspid is great for proprioceptive feedback, and patients like to have some sense of proprioceptive back in from the periodontal ligament. If you can at least keep one too. And I do like to keep the cuspids if I can. So here's the condition of the teeth. Not too good. Flapped it open, there are the teeth. Nothing here. This is okay here. Nothing here. There are our teeth. So we're going to place one implant in here and one implant in here. There are the implants. Now someone asked me about the position of that implant. Now this implant looks like a Blue Sky implant, doesn't it? As far as the platform, but it's not. It's a bone level implant. And it's a Cybron implant that I don't think they're going to be making anymore. But you can see here's the crest, the socket, and that implant is a couple millimeters into the socket. If that were a blueskybio implant, I would have this perhaps up a little bit more, because from here down is sprayed surface that will integrate, but on a 1.8 millimeter collar, I would never sink it down that far in the placement of the implant. Now these are blueskybio implants back here. These are the strong, bone level implants. So the posterior are tissue level, and the anterior is bone level. So this is closing it back up. Made him Essex retemporary, and you know this is so far up, and I want to give him a little bit of support for his lip. That's actually a replica of the occlusion teeth that he had. Here it's healed up. There are abutments, custom abutments that were made. These were a little bit of platform switch. You can see from here with a platform up to here. Plus this is switched in mesially slightly. You can see just how far this is caved in here on this side. And there's my final restoration. Two central incisors blended together with the conics left out. And that's the way it looks like in his mouth. There's the final restoration. Any questions? How long do I, on the provisionals? It all depends, but usually about 2 months. The Essex? Oh, the Essex? Well, you have to leave the Essex in until the implants integrate, and that's usually about 2 months. What else are you going to do? You can make it removable. They're comfortable with the Essex. At least mine are. Sometimes they'll lose one and we'll make two of them. Sometimes they need another one. You could also make a flipper, you know, but then I don't like the pressure against the implants themselves when you're doing them this way. That I don't like. But like in those cases, you can see that so from where you started here after removal of the teeth, and when those teeth were removed, this area here, we put grafting material in here and here. I could have augmented off on the labial, but in this particular case I didn't. I could have, but I didn't. I mean, you could go back in here and you could say, okay, extract these teeth, place grafting material, try to augment this, close it up, let everything heal up, and then go back in and do it at another time. But when you stop and you think about how far up this is in its smile line and you don't see anything, you cut down your total length of treatments, you know, significantly this way with the immediate placement. You can achieve, I don't think there's a necessity that you actually have to, but I think that the more grafting you do, especially on the labial on the outside, the better it is to achieve primary closure. But there are some instances where I don't achieve primary closure at all. You could see the earlier case where the cuspid, the cuspid that we extracted and did the CT graft and placed the implant in, we didn't achieve primary closure there. And we just kind of cinched up the tissue around the healing collar. I think if you're doing, even with ridge splitting, the times where we go in and we split the ridge and expand it, and place the implants at the same time, we don't establish primary closure with that. Sometimes we just take what's called collar coat and put the collar coat in. There can be 3-4 millimeters of distance between the buccal and the lingual. So for me, there's not a necessity for primary closure. I think that if you want to try to gain more tissue volume, you can gain more tissue volume by releasing the flap, pulling it down, getting your primary closure. And then when you go to place your healing abutments, go to the lingual, make your incision, and try to push that tissue to the labial to get more bulk of tissue. So that way, if your goal is to try to achieve more bulk, more tissue, primary closure can be good in that instance. Let's go here. This will be my last case that I'm going to show here. The last case is done. Good. Okay. Here's a situation where this particular female is going to eventually have probably all of the full mouth implants on the maxillary, but we're going to do it in segments. And I know that some people would prefer to do the whole arch at one time, but if the posterior teeth are good, they're solid, and let you know maybe perhaps if they're only going to be in there for 5 more years. If you gain 5 more years out of that, that's good. And you can break up the arch into anterior and posterior sections. So you can have anterior bridge work and then you can have posterior bridge work. And you don't have to have continuous arches and be locked into roundhouse bridges. So in this particular case, there is no possible way that I would do this if she had a high smile line. Because what are you going to do? I mean, you can see how much of the tooth you see right here, and here she's grinning, but you know, she's got tissue up to here. Now, if she had a high smile line, this would be a nightmare. And so I wouldn't even attempt to do it in that case. That's where your diagnosis comes in, your treatment planning is extremely important. So you can see where the level here of the tissue and bone considered in comparison to what she has in the anterior region. So this is definitely a case where, because of the amount of number of teeth that we're extracting, this is something that I wouldn't elect to do as an immediate placement, like the case that I showed you before. So here's the teeth extracted and the shrinkage that had occurred as a result of the healing. So when I extracted those teeth, I grafted those sockets. And sometimes you'll graft the socket, and I believe I was speaking with you, you go back in and all soft tissue invades the socket. The graft will totally unsuccessful. So this is one of those cases where that happened. So the ridge looks pretty good, but actually it wasn't. So I went in and I placed 4 implants. And then we gave her this removable appliance, and I lost one of my implants. It was a narrow neck implant, and I think it was because of pressure on the implant that I didn't relieve the underside of the provisional. So this is the temporary that she was using. There's some soft reline. Now the implants are already in at this stage. And this is, there's an implant right here, there's an implant right here. So what I did is I took her removable appliance that she was wearing, the flipper. I lost an implant over here, so I had to go back in and place another implant. But to pacifier and to try to make up for my mistake, I took her removable flipper and I changed it into a semi-rigid removable over the top of solid abutments. So it was more comfortable for her to wear. So we took the implant, placed a solid abutment here, that was a little polymethyl methacrylate acrylic copings, put those over the top, put her flipper back in and luted those together so she could take this on and off like a telescopic bridge. And this was how that temporary looked in her mouth, because now it's supported by implants on each side. So this is what we wanted to end up like with. But in order to have the correct amount of support in this area high and have these incisors at the correct position is difficult to do and convey all that information to the lab, because this is how much has to be built out in reference to where she was initially. So this is an implant here. I lost an implant. I went back in and placed an implant. And here's my implant, solid abutment, implant, solid abutment. And I waited until I made this temporary. So when I went back in here and placed this the second implant, I didn't have any pressure on that implant. So here shows solid abutment. There's a temporary coping. Now, I had to go back in and place an implant here, and there still is one already in here, but this is the area that I had to place a second implant. There's my temporary flipper that I cut the whole pallet out of. Here's the temporary flipper now that is converted over to a semi-precision type. There's my one solid abutments there and solid abutment there. And these little acrylic copings that are made on the analogs, boy, they fit so good that it's even kind of hard to pull them off. So she was really happy wearing this, and she was comfortable while we were waiting for the other implant to integrate. So again, here's the acrylic coping here over the implant. My partial's in position, and I just mixed up some more acrylic and glued it all together. So now I've got something that comes in and out. Not only do I have something that comes in and out, I got something that's somewhat stable, and I can use putty matrices in order to communicate all this information to the laboratory, for the laboratory to do the metal framework and add the amount of porcelain I need for her lip support. You could do this in denture teeth and acrylic resin, but if I could use porcelain and metal over acrylic resin, I like to do that. So I know this is a little bit out of sequence, but here's my what I thought after I extracted the teeth was where I was going to place my implants. Okay, but when I got in there, my graft had totally failed. There wasn't anything there. I was able to put an implant here and one here, but here I had to try to fit the implants in and put the temporary removable flipper back in, and I lost one of the implants. So this is what I mean. This is with nothing in her mouth, and this is with that removable in her mouth. So it's almost like she's undergoing a facelift when you take the removable and put the removable in the mouth to support all the lip. So with the thickness of this up here, when you change that thickness, it's going to change this border of the lip. If you look right here, you can see how there's no border there. But it's just the same person with no Juvederm injected into the lips at all. This is just the support of that acrylic from the removable. It's now sitting on top of the two implants that are integrated in the back. So now my other implant had healed. So now I'm ready to construct her final prosthesis. But when you stop and you look at this, if you give that to a laboratory, how are they going to know where to put the incisal edge? So what are they going to do, the wax up? You need to give the laboratory some references to do that with. So from here, these are going to stay in her mouth for this period of time. It's just going to allow me to have something that is a reference for support instead of making whole amount of arch of provisional acrylic restorations. I like the shape, I like the appearance of that, so that's what we wanted to duplicate. So, we'll unscrew this and take an implant level impression. So we take an implant level impression, or I should say, I took and left this in and took an impression. So there's the implants in the front. This is my solid abutment that I could screw into the implant level impression. So this solid abutment I screwed in to the implant is the same as what's in her mouth. It's not the same abutment, but they're basically the same. And it allows me to take and do my mounting and then send that to the laboratory. So I took that out of her mouth, and those that is one of the beauty of these solid abutments, is you could just screw them in and screw them out. So I had an implant level impression. I screwed that in. I took her removable out of her mouth, and I put the removable in there, and then I mounted that to her lower, which allowed me to control the occlusion, and then it also allowed me to give this reference to the laboratory, because once this was on here, then what I did is I just made a putty matrix of that to transfer it to the laboratory where the incisal edge position is going to be. So here's the putty matrix that we took. Then I took this off, and put that back in her mouth. Then I sent that to the laboratory. So you could see just how far we had to come out and how much we had to give her lip for support. So that's the putty matrix. So we sent this to the laboratory, and so the laboratory used this to use as a reference to wax up her metal framework. So we made the custom abutment for these two, and still we just left these in. So there's our custom abutments, and this is our final bridge work. So this is cement retained, and basically this dimension here, the laboratory was able to make based on the dimension that we had, we gave to them, and the putty matrix that we gave to them, that would give us this incisal edge position. So again, if she had a high smile line, this would be very, very, very difficult, if not possible to do. Or I would not even want to think about what I would do if she had a high smile line. So in essence, then we have one piece that takes care of our anterior. Eventually, when we go to treat these in the posterior, we can treat them one side at a time, or we can treat it both at the same time. You know, we might not do that for 2 or 3 years, 4 years maybe. But at least she's not going to have any kind of an aesthetic issue, because she's going to have her anteriors that are in place. So again, the solid abutment stayed in. When we took our impression, we took an impression that was implant level here and here, and it was abutment level here. So that's some of the versatility using the solid abutments, because that solid abutment, when you go and you put the temporary on here, it's firm for displacement, that she was comfortable wearing that extra 3 months period of time, because we lost that one implant. So there's the final prosthesis. That everything is porcelain and metal. Now, probably could have gotten by without even doing this pink porcelain on here, but you need the porcelain on there. It could have been white, but you need the porcelain on there for support for the lip, because unless you have that proper support for the lip, her lip is going to sink in, and she's not going to be happy with the amount of tooth that she's showing. So this incisal edge position that you're transferring to the laboratory, you can have an incisal edge position here, and these anterior teeth can be sitting like this, they can be sitting like that, different angles. And so this amount of contour here was important, because when this contour up here changes, the length, how that tissue drapes over the edge, you're either going to show more or you're going to show less teeth. So that's the final prosthesis cemented in. So this is the effect of what you're doing, and how without prosthesis in there, you know, the lip looks one way, and then when you put the prosthesis in and she puts some lipstick on it, totally changing. So to have the proper amount of support up here changes this nasolabial appearance. So that's our final prosthesis. And yeah, we took and we added paint to that, but still. And so that's our final end result. And you can see this curve up here and how that supports this angle that she was happy with. But I'm finishing about a long time ago. So the degree of difficulty is not consistent for all the patients. So some patients are going to present problems that are much more difficult and challenging. But I think that if you make implants your first option for treatment, your patients are going to, once patients go from something that's removable and not firm to utilizing implants, they never want to go back to not having implants. So I would recommend that you highly make implants your first option, that you always remember that you want to start with the end in mind, you want to work backwards, you want to plan your work, and thank you for your patience. Thank you for giving me the opportunity to present this information to you. I've enjoyed myself this afternoon. The only thing is the weather in Taiwan. I wish it could see a sunny day. I've been here for 2 days and I haven't seen any. So I'll be happy to answer any questions that you have at all. Yes.
I would like to know, do you get the connective tissue graft from the tremolar pad?
I take the CT graft from most of the time because it's, as opposed to taking it from the palate, you know, it's minimal healing. It's very comfortable. So due to the length and the size that I'm taking, I normally take it from the retromolar pad area. Now, if I were doing connective tissue grafting to try to cover root surfaces where you need longer strips, then you have to take it from the palate.
Lower tremolar pad.
You can take it from the lower. You can take it anywhere that you want to take it from if there's thickness of connective tissue there. And for every patient, it's going to be a different site and a different option. Okay, socket augmentation. I wish I could get on my computer and I could show all that, but you're talking about extracting the tooth and preserving a site to go back in and place your implant. If there's no fracture in the plate, if there's no fracture in the plate, and I extract the tooth, I take my curette and I run my curette up on the labial wall and I can see whether or not everything is intact. I give patients an option. If we're going to extract the tooth, I tell them, we're not doing an immediate placement because maybe I don't have the time that day to do it, or we didn't plan on extracting the tooth or whatever, but they've decided that they want to have an implant. I tell people that if you want to have an implant, you commit to an implant, I can save you some money in your treatment. We won't have to do any socket preservation. If you tell me you're going to come back and I'm going to replace your implant in there in 4 weeks. So if you come back in 4 weeks and I place an implant in there, why do I need to do a socket graft? You don't need to do a socket graft. So you tell them, you can save yourself the money for the socket graft and apply that toward your total implant fee if you start treatment in 4 weeks. If you don't want to start treatment or you don't think you can, and you want to place an implant, then we need to preserve that area for future placement if possible. So if I'm going to go back in and place an implant, within 4 weeks, I don't graft the socket because I think it's a waste of time. So I will just allow it to heal up so I can kind of get enough tissue there for healing and for because I can always go back in and place the implant with closure of that tissue. Okay, so I don't feel like I need to do that. But if I'm going to do a socket preservation, I use the mineralized freeze-dried bone, which is DBEA. And you can't use that here in Taiwan, I understand. And that's the material of my choice. And when I use that material, I use that material, and then I don't try to establish primary closure. I use a membrane that's made by Osteogenics. It's a cytoplast membrane, it's a PTFE, and I place the graft material in there, and then I tuck that membrane on the buccal, tuck it on the lingual, and then leave that in for 4 weeks. 4 weeks. Exposed. And what happens is at the end of 4 weeks, you can just go back in and pull them right out. Actually, I use that membrane at times, even if I'm doing an immediate placement. Like, I have a case, like I can't get to my computer because it doesn't work here, where we extracted tooth. There's a little bit of a perforation of the plate. Place the implant in. Take that, place the grafting material there. This is immediate now, so there's an opening there. Take and put that PTF membrane over the top of that. Tuck it over on the lingual. Don't put a healing collar, put a flat cover screw in there, and leave it in for 4 weeks, and then pull it out. And when you pull it out, you're going to have all soft tissue underneath there. It's a great membrane to use to prevent you from having to go with primary closure. So it contains the graft material, it keeps it in place, and allows the tissue to grow underneath it and preserve it. And I have some of my patients that will just pull the membrane out themselves. It's kind of a, have you ever used one of those membranes? It's.
I saw one outside.
Okay. Yeah. They're fantastic. It's like you go to pull it, and you need a hemostat on it, and it doesn't hurt. There's no pain for the patient. And then they just pull it, and then all of a sudden, it just comes out. There's a little bit of resistance, and then the membrane just comes out. They're fantastic membranes. But so it's a combination of the freeze-dried bone and that membrane. If I want to, if I'm going to go back in and place an implant, I don't feel the need to do any graft. Any more questions? And those membranes you can get if you want to do, and I think in the general population that you have here, with the types of premaxillas that you have, those membranes also have titanium reinforcement. So you can take and kind of shape them and graft and place those in. And the bottom line is you must maintain a space. If you maintain a space, you get a blood clot, keep the soft tissue from invading that space, bone is going to fill it. Yes. That's the beauty of it. Okay. Yeah. Thank you very much.
很谢谢各位医师今天光临来指教。那还没有换那个停车的，麻烦外面有小姐会为你服务。各位医师如果对今天的那个内容呢有需要我们提供PowerPoint 内容的话，麻烦赵丽留下你的联络的 email 以及联络电话。
明天早点来稍微讨论一下。
9点半，你也是9点半才
没有
来。
9点不行啊，早点来了。
你不要我到了，你都没到。
我一定要到。你能不能办好吧？你
怎么了？
我跟你讲啊，如果说那个2次植牙的话，第一次植牙种完之后啊，那牙龈萎缩，牙龈回来是2个mm。那怎么做这个东西？就是你第一次把它种进去嘛，然后整个都散沫才在里面嘛哈，然后因为这经过一段时间之后，它这个水体牙龈下来，那它只有2个mm的厚度。那但是2个mm的厚度，如果再接那个邦的米上来的话，这个变成
如果有想要
很薄了，这边会看不出，会看到那个牙龈，而且没办法把前面的丰隆度做出来。那这个怎么做出来？你懂我在讲什么？
我懂意思，可是这样子应该不太好做。
啊。那还有一个问题，我有一个 case 就是说哈，这个牙龈，的话要。
丢，你没有你自己是问。啊，谢谢你，谢谢。可以啊。好。这个要跑给他。他是在这里来，之前好像